Hey, good afternoon, and welcome to the Department of Medicine Grand Rounds. Today, this is, as usual, the combined rounds for the Hamilton Health Sciences, St. Joe's, and the Academic Department of Medicine. I'm very pleased to introduce our speakers today, three of our best chief medical residents. Manan Ahuja, who's graduated from McMaster University and continuing to do a fellowship next year in geriatrics at McMaster, and Sagar Patel, who's graduated from UFT and will continue with a fellowship in rheumatology at McMaster here as well. Also, Aarushi Bansal has contributed to this presentation. However, we work our residents very well, so she's post-call. She couldn't make it to the presentation. She also graduated from UFT, and we're keeping her at McMaster for cardiology, so it's our win. The supervisor for the presentation today for the grand round is Dr. Amanda Hoon. Dr. Hoon is assistant professor in the Department of Medicine in General Internal Medicine and also obstetrical medicine. The topic today is 3 common obstetric medicine topics every internist should know. I'm very excited to listen to our speakers today, as I need to learn something about obstetrical medicine, like every one of us in GIM and internal medicine. So without further ado, I'm going to pass it on to our speakers.
Thanks so much, Dr. Azam. Appreciate the kind introduction. And hi, everybody. Thank you for joining us. Sagar and I, as Dr. Azam mentioned, are both PGY 3 residents, and we're very excited to present the topic of 3 common obstetric medicine topics that we feel every internist should know. As you know, none of us are headed towards that field as of yet, but part of the reason for inspiration for this topic was some related to a royal college study, and part of it was related to our lack of exposure to pregnant individuals on day-to-day medicine, something that we feel like every internist should know. We also want to thank Aarushi for her contribution, and unfortunately she couldn't be here today. Before we get started, we just want to make some line acknowledgements. We recognize and acknowledge that the students of McMaster University meet and learn on the traditional territories of Mississauga and Haudenosaunee nations, and within the lands protected by the dish with One Spoon Wampum, an agreement to peacefully share and care for the resources around the Great Lakes. Just an overview of our talk. We're talking about 3 main topics today. The first one is providing an overview of management of hypertension in pregnant individuals with evidence for blood pressure targets in this group, and briefly talking about acute management of preeclampsia, but not necessarily a big focus on prevention of preeclampsia. Our second main topic is VTE, so guidance around VTE diagnosis and management for pregnant individuals. And the third topic is providing an overview and management of options of different pre-existing and antepartum thyroid disease in pregnant individuals. Just want to let everybody know we're not experts in these fields, but we hope to prevent evidence-based approaches to these common medical comorbidities that we see in the general population that we may or may not know how to sort of manage in pregnant individuals. And lastly, we just want to thank Dr. Amanda Wynn for all her help supervising and her feedback with this presentation. So without much further ado, so the first part, as I mentioned, is hypertension in pregnant individuals. Before we get into that, I just want to briefly summarize some of the common hemodynamic changes we see in pregnant individuals. The 3 main ones I want to talk about are increased in preload, which is related to an increased blood plasma volume, a reduction in afterload, and that's mainly, it's multifactorial, but mainly related to a decrease in systemic vascular resistance. And that's related to a lot of things that's been studied, including decreased effects of angiotensin II, increased production of hormones during pregnancy, such as estrogen and progesterone, that sort of taper off later in pregnancy, along with various other humoral factors, and an increase in heart rate. But overall, the effect of this is an increased cardiac output in pregnant individuals. In terms of how that sort of changes, specifically how blood pressure changes throughout pregnancy, this was a small observational study done by Manan et al. In 2014, where they really mapped out what your mean arterial pressure along with your systolic and diastolic pressure does from pre-pregnancy to postpartum. And as you can tell, it sort of decreases until the second trimester and then sort of tapers off, which sort of coincides with some of the mechanisms that I'd mentioned earlier related to the increased hormone production early in pregnancy. And that's sort of how it tapering off in the third trimester and postpartum, of course. Interestingly, this study monitored a lot of different hemodynamic parameters, including cardiac index, cardiac output, heart rate, throughout pre-pregnancy and postpartum stages, which was very interesting. So moving on more specifically to hypertension classification in pregnancy. So pre-existing hypertension in pregnant individuals is generally defined as hypertension, and we'll talk about targets shortly, before the gestational age of 20 weeks. Whereas gestational hypertension, which is sort of new onset hypertension, is generally after the 20-week gestational mark. Preeclampsia is another related hypertensive disorder, specifically in pregnant individuals. Generally, with people with gestational hypertension, but not always, as chronic hypertension is a significant risk factor for preeclampsia, and it's hypertension with one of the following end organ dysfunctions. So the most commonly one that we talked about is proteinuria, and sort of defined how you measure proteinuria. It's generally, if you're doing a spot urine, greater than 30 milligrams per millimole, or if you're doing a 24-hour urine sample, it's greater than 0.3 grams of protein in the urine, or one of these adverse events in the pregnant individual or the fetus. So some of the symptoms could include headache, visual symptoms, chest pain, dyspnea, having a lower O2 stat, nausea, vomiting, right upper quadrant pain with some hepatitis, and then in the fetus, abnormal fetal heart rate and intrauterine growth restriction. These can be further complicated into severe complications, which could be eclampsia, so seizures, stroke, pulmonary edema, having an MI, AKI, synthetic dysfunction of the liver with an elevated INR, and then unfortunately for the fetus, placental abruption and stillbirth. So you only need one of A, B, or C and hypertension to actually diagnose preeclampsia. In terms of the official diagnosis of just hypertension itself, so in pregnant individuals, it's generally similar to non-pregnant individuals, where you have a office or in-hospital reading of greater than 140 systolic or greater than 90 diastolic. And in the ambulatory setting, greater than 135 systolic and greater than 85 diastolic, which is generally similar to non-pregnant individuals. And generally, you want 2 blood pressure readings, you take an average of the 2, and you want them 15 minutes apart, as you would in any other patient you would see. Interestingly, the categorization of severe hypertension is a little different compared to non-pregnant individuals, at least according to Hypertension Canada. Pregnant individuals, it's a blood pressure greater than 160 over 110, whereas in non-pregnant individuals, Hypertension Canada defines it as greater than 180. But same sort of process of reading the blood pressure. Now we talk briefly about high blood pressure in pregnancy. How do you treat it? So we've generally categorized it based on non-severe hypertension treatment, so mainly outpatient treatment versus severe hypertension treatment, so inpatient treatment that requires monitoring. So outpatient treatment, the first-line drugs are generally 3 drugs, and I've listed them here: methyldopa, labetalol, and the long-acting nifedipine, not to be confused with the immediate-release nifedipine, which is used more treatment for immediate blood pressure control and in severe hypertension. And I've listed some of the starting doses along with the maximum doses here on the PowerPoint slide. There are also various second-line agents you can use that I have not listed, including clonidine, hydralazine, if these 3 drugs do not work. But it is also important to mention that drugs that we would normally use in non-pregnant individuals, such as ACEs and ARBs, are teratogenic to the pregnant people, to the fetus, and are not recommended in the use during pregnancy. Now, for severe hypertension, once again with the blood pressure greater than 160 or diastolic greater than 110, which I could generally recommend something more immediate acting, such as labetalol, immediate acting nifedipine, which you can give orally, and hydralazine. And generally, you want to repeat blood pressure in an inpatient or monitored setting every 30 minutes to ensure it's met your parameters of less than 140 over 90. But we'll talk a little more about that. So this is a lovely diagram from Hypertension Canada, sort of outlining what I've just mentioned in a more succinct manner. Generally, if you have severe hypertension based on the algorithm, it's an obstetrical emergency and you want to initiate pharmacotherapy immediately in a monitored setting. So whether it be emerge or under OB med in an inpatient setting. But if it's elevated but not severe, you want to generally start antihypertensive and do close monitoring, whether it be initially in the inpatient setting and then outpatient setting, not only for the maternal monitoring, but also fetal assessments as well, until your diastolic is generally less than 85, but we'll talk about the targets shortly. So moving on to blood pressure targets. So the SOGC generally recommends a diastolic blood pressure that's less than 85, and I'll talk about how they came up with this specifically, and generally a systolic blood pressure between 130 and 140 millimeters of mercury. There's not as much consensus on this yet, but that's generally where you want it recommended. And there are two main trials which really investigated this and came up with these targets. The first trial is the CHIPS trial, which is the Control and Hypertension in Pregnancy trial, which was published in NEJM in, I believe, 2015. And essentially, it was a randomized controlled trial of pregnant individuals in which they compared less tight versus tight control of hypertension. And their primary composite outcome was looking at various pregnancy-related complications. So less tight was a blood pressure of less than 85 millimeters of mercury, whereas not as tight was around a diastolic of 800. And in the end of the trial, unfortunately, they did not find any significant difference in their primary outcome, which was sort of pregnancy loss, miscarriage, having the baby within neonatal care postpartum for greater than 48 hours. There was no significant difference between these two markers, but there was a significant difference in their secondary outcomes, which I'll show on the next slide, which was essentially less incidence or statistically significant decrease incidence of severe hypertension. The other trial we wanted to sort of talk about was the CHAPS trial, or the CHAP trial, which was a chronic hypertension and pregnancy trial, which was published in NEJM in 2022. And essentially, they compared treating hypertension in pregnant, as a randomized control trial as well. And they compared treating pregnant individuals with a blood pressure less than 140 over 90, as we would for a non-pregnant individual, versus treating blood pressure that is only in the severe range, so above 160, or if the diastolic is above 110. And they found that the more tighter control of diastolic and systolic blood pressure was associated with better pregnancy outcomes, which I'll sort of show on the next slide. So this is an overview of the CHIPS trial, the first trial, and this was the secondary outcomes, which are outlined as statistically significant. So as you can see, the more tight blood pressure control of a diastolic less than 85 had lower incidences of severe hypertension and lower laboratory abnormalities, specifically a thrombocytopenia and hepatitis, or elevated AST and ALT. Whereas in the CHAPS trial, this was the one with a blood pressure of less than 140 over 90 versus just treating severe hypertension. And they had a statistically significant decrease in the treatment group of their primary outcome, which included preeclampsia with severe features, a preterm birth of less than 35 weeks, placental abruption, and fetal or neonatal death less than 28 days. So moving on, so this is sort of our blood pressure management in the outpatient setting and non-severe instances. But I just want to make a quick note about preeclampsia. So preeclampsia is an emergency. It requires close monitoring, as we all know. And these are sort of the 5 postulates that are important to remember in treating preeclampsia in pregnant individuals. So the first one is blood pressure control. It's important to note that generally preeclampsia is related to ureteroplacental dysfunction. So the blood supply and the nutrients the placenta wants it's not what it's getting, and that leads to a lot of oxidative stress, a lot of radical oxygen species production, and a lot of the end organ dysfunction that I mentioned in the diagnosis of preeclampsia. Blood pressure is also a manifestation of preeclampsia, so it does not prevent preeclampsia, but it should be controlled during its management once preeclampsia is diagnosed. Apart from blood pressure, you want to ensure you're monitoring fetal conditioning continuous fetal heart rate monitoring. You want to give preeclampsia or eclampsia prophylaxis with magnesium sulfate, and we can talk about this in the question and answer period regarding dosing and what you would give, but essentially it's important for eclampsia prophylaxis. You want to think about the timing of delivery with your OB colleagues in terms of the gestational age, what chronic condition the patient has, whether it's chronic hypertension, or in this case, preeclampsia, and what will be the most appropriate course. And you want to think, once a baby has been delivered, about postpartum care. And the reason you want to think closely about postpartum care is postpartum hypertension is a very important, it's very prevalent in pregnant individuals. About 25% of people who experience hypertension associated with pregnancy, it generally occurs in the postpartum. 25% occurs in the postpartum, and up to about 6 weeks, but generally about 3 to 7 days postpartum. And this is multifactorial. It could be partly related to the fact that a lot of the the progesterone and estrogen that was initially producing, that was causing the vasodilatory effects early in pregnancy, aren't there anymore. It could be related to pain and the fact that you just delivered a baby. Some postulates are related to like giving IV fluid around pregnancy, but generally that's when you're at biggest risk. Postpartum preeclampsia, though less common than postpartum hypertension, can occur in about 5% of individuals. So that still needs to be, as an internist, seeing these patients postpartum on the top of our differential for patients with high blood pressure that may present up to 6 weeks postpartum. But the management in this is quite similar to the management in during antepartum as well. Moving on, Sagar and I will briefly be talking about VTE in pregnancy as well. So VTE in pregnancy is why do we care? There are many reasons we care. One, it's it's more difficult to diagnose, as pregnancy-related changes also kind of interfere with some of the classical signs we would see in VTE. As I mentioned earlier, some of the hemodynamic changes we see in pregnancy, including elevated heart rate, which is something we would look for in the diagnosis of PE, lower leg swelling, which is something we would look for the diagnosis of VTE or DVT. And generally, there's also dyspnea associated with pregnancy that is already occurring at baseline. So sometimes it may be hard to differentiate, but it's very important that we have a high PHS probability given the incidence of VT in pregnant individuals. So peripartum, it's about a 5 to 10-fold higher risk compared to non-pregnant individuals. And then the highest risk is actually after the baby is delivered, about 6 weeks postpartum. So once again, that high risk 6-week period with the elevated risk of about 15 to 35 fold more likely compared to non-pregnant individuals. So in terms of when to suspect DVT, so in terms of some of the physiology associated, given you have a fetus in your uterus and sort of compressing down, DVTs generally occur more likely in the left leg due to compression of the left common iliac by the right common iliac vein. And as a result, you see more proximal deep vein thromboses. So the highest, as I said, is 80% in the left leg, 64% in the iliofemoral, and then about 17%, so less likely, in the isolated iliac vein. And majority of them occur proximal as opposed to distal. So when you do order a compression ultrasound, you want to ensure that you specifically request proximal veins to be also compressed and visualized to rule out a DVT in this patient population, because sometimes based on the area, these may not be routinely done. And in terms of if you have a high pretest probability for a DVT, you do an ultrasound initially, but that doesn't necessarily rule out the DVT based on the guideline recommended by Thrombosis Canada. Generally, if you have a high enough pretest probability, you want to repeat the ultrasound twice within 3 and 7 days to ensure that a DVT is not missed, and then clinically follow up.
So I'll just continue in terms of the VT topic. Thank you, Manan, for going over DVTs. And in terms of pulmonary embolism, the challenge in pregnant patients is that there are symptoms which can be physiological change because of the changes in hormones. So like Manan was talking about, you can sometimes see an increase in heart rate, and that could be physiological, especially more in the first trimester, as well as dyspnea, which patients can start experiencing in the first trimester as well. And so going over an approach to PE is important because as internists, we learn about the Wells criteria for DVT and PE. However, pregnant patients were excluded. And so there have been multiple studies that are done, and we'll go over the years criteria, which uses both clinical symptoms as well as D-dimer, mostly to rule out to rule out PE. And the reason is because we don't want unnecessary exposure to radiation, both to the mother and the fetus. There's a chart right here which sort of outlines how much exposure you get through a CTPA versus a VQ scan, both the fetal dose and the maternal dose. One thing I will mention is that an accepted exposure is 50 milligrams, 50 milligray of radiation to the fetus. And so, a CTPA1 or a VQ scan, is well below that accepted range. However, still important to have a discussion with the mom about the risks to her and the baby. And so what we'll be going over is the Artemis study. And here, this was a publication in 2019 where they included 510 pregnant patients, and they did a prospective cohort study. And what you will see is that the years criteria, it actually uses three of the clinical criteria in the Wells PE score, and they just took the most important what they thought that was the most important questions to ask, and they combined that with D-dimer to figure out if a combination of these two things can rule out PE in these populations. And so the years criteria asks about if there's any clinical signs of DVT, if the patient has hemoptysis, or if PE is the most likely diagnosis. And we'll go over the algorithm as well in terms of the cutoff for the D-dimer. But just to kind of go over the outcomes, what they found is that when they did use the years criteria, and they followed these patients up afterwards, since it was a prospective cohort study. And those patients who were ruled out using the years criteria, none of them had a PE. And only one patient out of all that were included ended up having a DVT. And this was after 90 days of follow-up, and it was a symptomatic popliteal vein DVT. And so they did a further meta-analysis in 2021 that looked at 4 different trials, including the Artemis study, and they found that the years criteria is really good at ruling out PE, and it has a negative predictive value of 100% for this criteria when there's a low to intermediate pretest probability, meaning that we can provide some reassurance to our patients, as well as prevent any unnecessary radiation exposures. To go over the diagnostic algorithm, so the 3 questions: the clinical signs of deep vein thrombosis, hemoptysis, or PE as a most likely diagnosis. If you suspect DVT, or if there's clinical signs, you go down the DVT pathway, as Manan alluded to, and you would order Doppler ultrasounds, specifically also looking for proximal vein DVT. And if there's abnormal compression, you go straight to anticoagulation. However, if they meet any of the other clinical criterias, or if they meet clinical signs of DVT, however, their compression ultrasound was negative, then you look at how many criteria they met. So none of the criteria, or 1 to 3, and then you use a D-dimer score to figure out if you can rule out PE. So if they have no years criteria, but clinically you still suspect that PE could be on the differential, if the D-dimer score is less than 1,000, you can rule out PE. However, if the D-dimer score is greater than 1,000, you would proceed to ordering a CT PA. And then in terms of if you have 1 to 3 years criteria, the D-dimer threshold changes to if you have less than 500, you should you can rule out a PE, and if you have greater than 500, you should order a CTPA to further investigate. And I think the main thing I wanted to highlight here is that the D-dimer is really important in pregnant individuals because in the first trimester, the D-dimer is the lowest, and physiologically D-dimer starts accumulating throughout the trimesters of pregnancy. And so when using this score, it's also important in the discussion of the Artemis study, they did mention that this is an algorithm, although they didn't differentiate between the different trimesters, that this algorithm it would be better suited for first trimester, although for the meta-analysis and for the Artemis study, they didn't exclude second or third trimester pregnant individuals. And so this study, again, this slide highlights sort of the cutoff. So again, 0 years criteria. If you have a D-dimer that's greater than 1,000, you would image them. If it's 1 to 3 years criteria, you need a D-dimer of greater than 500 to image. Otherwise, if they don't meet this D-dimer cutoff, PE can safely be ruled out in the low to intermediate pretest probability population. In terms of treating VTE, again, these are just the basic principles that as internists it's important to know, but so you want to avoid warfarins and DOACs as they're teratogenic. Warfarin is safe during breastfeeding, and if you were going to anticoagulate a VT during pregnancy, you would be using heparin, whether that be unfractionated or low molecular weight heparin. In terms of duration, the duration is at least 3 months and 6 weeks postpartum if this is a provoked VT due to pregnancy. And it's important to highlight the and, meaning if a patient was diagnosed with a PE in first trimester, although by the end of second trimester, they would have had 3 months of anticoagulation, you still need to continue the anticoagulation 6 weeks postpartum. And this alludes to the point highlighted by Manan earlier that 6 weeks postpartum, it's the most thrombogenic period and the highest risk. In terms of frequency, there's no difference in daily or BID dosing. And when you think about anticoagulation in terms of pregnancy, you want to also speak to anesthesia and your OB colleagues because this is going to have to be a planned delivery, especially because you can't give an epidural, or it's very high risk to give an epidural while on low molecular weight heparin unless you hold it 24 hours before. And so coordinating this in a multidisciplinary setting is really important. And then in terms of when to resume, really, it depends on if it's vaginal or C-section. And of course, you would be having this discussion in conjunction with the obstetrician as well. There's a few things we'll go over in terms of thyroid disease in the pregnant populations. The main objective is to give some major takeaways. So the first is, if a patient has pre-existing thyroid disease, what do you do with this patient? And so the general rule of thumb is that you need more T4 when you're pregnant, about 30 to 35%. And so this equates to doubling their dose on Saturday and Sunday if they were to take it, if they were taking levothyroxine daily. And then after delivery, you're reverting back to their normal dose and you're targeting a TSH of less than 2.5. So pre-existing thyroid disease, depending on where you are and where you're practicing, it would usually be the endocrinologist who's handling that. But depending on if you're in a rural setting or if you don't have access to the consulting specialist, that's the sort of general takeaway. In terms of subclinical hypothyroidism, so this is important because we want to treat we want to treat according to whether or not they're TPO antibody positive or negative. And so the general principle is if the TSH is less than 2.5, it's still there's no treatment. But if it's if it's above 2.5, then you want to consider treatment. And so the normal range is somewhere between 1 point something and 4. And so even if you have 2.5, even if you have a TSH of 3, which if we're looking at the adult population, you would be thinking this is a normal TSH. I don't necessarily need to treat it. For the pregnant individual, you want to order a TPO antibody if it's above 2.5. And then if they're antibody positive, you want to treat if it's between 2.5, if it's between 4 and 10, and you want to consider treatment above 2.5. And so a good way of thinking about it is if they're TPO antibody positive and they're 2.5 and above, you're likely going to treat it. Again, you'd be consulting with a specialist to help you manage that. If they're TPO antibody negative, then there's no treatment between 2.5 and 4. However, between 4 and 10, you can consider treatment. And I think knowing sort of when to consider treatment and not, I think is above, I think it's out of scope for the general internist. And I think that's a time when you would be seeking expert opinion on this regard. And then TSH greater than 10, regardless of what their antibodies are, you would be treating them. And again, the TSH target is less than 2.5 during gestational pregnancy. In terms of thinking about thyrotoxicosis and Graves, so the main takeaway is in this diagram, what you can see is that beta HCG can stimulate the TSH receptors, and so you can have physiological changes where T4 activity can be increased, and this usually starts about 7 weeks of gestation and peaks at 16 weeks. And the main I think way to differentiate whether or not you should be treating this patient is to figure out, is this gestational thyrotoxicosis? Are there any specific scenarios where they can have increased beta HCG, such as if they have twins, triplets, if they have molar pregnancies, if they have choriocarcinoma, where you're seeing this T4 that's elevated, but you can't explain it, versus if you have true Graves' disease. The reason to differentiate this is because antithyroid drugs are teratogenic. And so there's different ways there's certain clues that can help you differentiate Graves versus gestational thyrotoxicosis. And in terms of gestational thyrotoxicosis, you wouldn't treat, you would manage symptomatically with a beta blocker. But for Graves' disease, again, this would be something you would consult a specialist before starting, but it's important to think of these things as a general internist so you know when to refer and who to refer to. But certain clues that point you towards Graves include Graves ophthalmopathy, a thyroid bruit, if they have goiters, if they're TRAB positive, if they have certain nodules. And here, if you were going to be using an antithyroid drug in conjunction with an endocrinologist, it's important to know that you would be using PTU in the first trimester and methimazole after, which is different than in the adult population where the first go-to antithyroid medication, if they don't qualify for radioablation or thyroid surgery, is to use methimazole. And the reason is because PTU is, although both are teratogenic, PTU is less teratogenic. And again, at all times, you want to be evaluating whether or not you can discontinue the antithyroid drug throughout pregnancy. If you are going to be treating in conjunction with a specialist, it's important to know that you're aiming for a high to normal T4 rather than in the non-pregnant adult patients, which we might be used to, where sometimes we're trying to suppress suppress T4, and the reason is because you want to try to use the lowest possible dose of the anti-thyroid drug. in terms of ordering antibodies for patients with Graves or even previously treated. So, for example, if you have a patient who's on levothyroxine because they because they had radioactive ablation or thyroidectomy, and so although they had Graves in the past, it's now treated and they're hypothyroid and they're taking a supplementation. It's important to get that history of Graves, because if they do have that, they could still they have a higher likelihood of having TRAB antibodies, and so you want to order TRAB antibodies in the first trimester and then beyond as well, and continue to follow that. And the reason is because if they are TRAB positive, there's an increased risk of fetal thyrotoxicosis, and so you want to alert the obstetrician to monitor for this. So thank you for listening to both Manan and I for this ground rounds, and we're happy to take any questions.
Thank you, Manan and Sagar. As usual, if you have any question, please put it in the Q&A, or if you want to ask your question in person, please, or not in person, ask your question by voice, please raise your hand and I'll bring you in. And Amanda, Dr. Nguyen will be moderating the questions for us today. So I think there's one question, Amanda, in the Q&A.
Yeah, I can. Thank you. So I can read that question. So that's from Dr. Prabtani. He's asking specifically about aspirin in the context of hypertension and pregnancy.
Absolutely, Dr. Prabtani. Aspirin is very important. So we didn't touch on it, but it's more used for preeclampsia prevention as per the ASPRE trial, which they usually recommend 81 to 160 milligrams of aspirin daily in individuals who are pregnant, generally started less than 16 weeks of gestation. And usually it's for people who have risk factors. So people with high maternal risk factors who would warrant this would be if they've had a previous incidence of preeclampsia, chronic hypertension, renal disease, diabetes. And those were the people who would benefit the most with aspirin for preeclampsia prevention. But not as much, obviously, for the acute treatment, which is what I only talked about.
There's a question.
I think Dr. Prabtani is it a follow-up to the question, Dr. Prabtani? There's a hand up from you.
No, can you hear me?
Yeah.
Well, first of all, Sagar and Manan, that was a fantastic presentation. And I'm glad you put 2 endocrine topics as part of your 3. I consider hypertension as an endocrine issue also quite a bit because I do quite a bit of it. But I think your thyroid presentation was very, very concise. And the thing with the antibodies and not having antibodies, I just wanted to point out, it's very controversial. It's based on very poor studies, but it's standard of care. It is what it is. And if you look at the US guidelines, the European guidelines, and the Canadian guidelines, they all have some overlap and some differences, but I think it's reasonable what you put down to avoid confusion. Often a referral we get is people who have a very low TSH and a mildly elevated free T3 in the first trimester with severe hyperemesis. So the thing is, the alpha subunit of HCG and alpha subunit of TSH are very similar. That's why you get HCG actually will suppress TSH as a negative feedback. And these patients don't have thyrotoxicosis. So in the first trimester, if they're having a lot of nausea, vomiting, but there's no goiter, negative antibodies, they're clinically not thyrotoxic, we would not treat those patients. That's very important because you're just treating hyperemesis and basically then beta HCG effect. That's really, really important. No. Second point that I wanted to make is that the free T3 assay in pregnancy is terrible. It's not even that great in adults to begin with, but it's not the greatest assay. Especially if your free T4 is low, I'd be wary of really paying a lot of attention to the free T3 on its own. So I just wanted to point out those 2 important pearls for the audience.
Thank you so much, Dr. Prabtani.
Great, thank you. And it looks like we have a question from Dr. Levine as well.
Okay, yeah. So thank you for the presentation. It's very, very practical information that was provided. My question relates to the beta blocker use in the hypertension. Often people are always suggesting labetalol, and yes, it has a convenience of IV access when you want to avoid PO and you need IV. But is there any evidence anywhere that suggests that labetalol has any superiority over things like metoprolol or propranolol or nadolol in the use of beta blocker for hypertension management?
Not that I came across for the pregnant individuals. The only thing that I came across in terms of beta blocker use was to avoid atenolol. Not that it's commonly used anyway, but that's teratogenic. I'm not sure, Dr. Wynn, if you know better.
And maybe I can comment on this a little bit. So I think, labetalol is there's no evidence of harm against like metoprolol, for example, and propranolol is often used for like Sagar and Manan had mentioned, for like thyrotoxicosis and symptoms related to that, sometimes even for migraine prevention. So these are medications that can be used in pregnancy. Even metoprolol has been used for like symptoms like SVT or high rates of ectopy or found in pregnancy as well. But my understanding is that labetalol probably has the best blood pressure related effect compared to other beta blockers that may kind of have better contribution. But I don't know if there's any direct head-to-head comparisons in literature from these beta blockers.
Okay, thanks.
I just want to add to that. I'm not too sure what the evidence is behind this, but while studying for the Royal College, one of the things that was pointed out is that for peripartum cardiomyopathy, so not for hypertension, metoprolol is more preferred than labetalol, and that's as it's more cardioselective. And so, I think that is, I guess, an instance where I would maybe use metoprolol over labetalol if they had both hypertension and cardiomyopathy, cardiomyopathy.
Thank you. And there's a comment about labetalol in the chat right there. Says labetalol has alpha blocker activity too, so that might come in handy. And I agree. So that's great. Are there any other questions, Dr. Levine? Did you have a second one, or
No. I'm fine. I'll take down my hand.
Okay, thank you. Maybe I'll ask a question for you guys. In any of your literature review and anything, have you guys come across any comments on what the implications of high blood pressure in pregnancy has towards like long-term health for these women, and how would you go about kind of counseling these patients regarding that? Because this is, I think, as internists, we would post their pregnancy, reproductive age, we would encounter these patients on the wards sometimes, or even in our clinics who have all these cardiovascular concerns. So is there anything that we should note or highlight in these cases where they're presenting young with these potential risk factors?
So I can briefly comment on that. So the thing that I came across in literature associated with sort of counseling are sort of a couple things that I mentioned. So if they've had preeclampsia or hypertension, they're at increased risk for future incidence of chronic hypertension, and gestational hypertension, which puts them at risk for preeclampsia. So I think just ongoing monitoring and educating them about the importance of monitoring blood pressure if they are pregnant and had gestational hypertension and they would like to get pregnant again, the importance of monitoring that from that perspective. I think some of the risks associated with hypertension are similar for a pregnant versus non-pregnant individual. And then I think it would be important when they do want to get pregnant again to have a very safe and appropriate reproductive plan. Because if they've had high blood pressure, regardless if it's gestational or not within a pregnancy, that's higher risk for future pregnancies. So either with their internist, family doctor, obstetrician, depending on who's in their level of care, recognizing that and having appropriate monitoring of blood pressure, as they're trying to conceive and once they're actually pregnant would reduce their cardiovascular risk.
Great. So I agree that I completely agree with you that there needs to be careful kind of consideration and counseling moving forward in a subsequent pregnancy because of the implications of any hypertensive disorders in pregnancy. And, those with chronic hypertension are definitely at risk, as you mentioned, of preeclampsia. There's been a lot of studies recently that demonstrate also that any hypertensive disorders in pregnancy, but notably preeclampsia and maybe will put women at risk, even down the road, about 2 to 4 times the risk of any cardiovascular kind of complications. And like you said, that could be chronic hypertension, that could be diabetes, that could be stroke, that could be anything kind of cardiovascular. So it's interesting because we, when we see patients on the GIM ward who come in with like MI-like symptoms, we screen for their cardiovascular risk. But one of the things that we do not comment on or ask about in women or these patients are whether or not they've had a history of preeclampsia, which, I would argue that perhaps this is one of the things that we should probably think about on the wards regularly. So there is another comment by Pete Kavsak. What do you think is the best for predicting preeclampsia? PLGF or S-FLT1 to PLGF ratio? Are you guys able to comment on that?
I'm not sure what's the best. I know those are recently introduced in the SOGC guidelines in 2022 in terms of FLT. One, if it's increased, you're at an inflammatory biomarker, you're at increased risk for preeclampsia. The ratio depending on the assay, and then reduction in the placental growth factor. I know there are risk calculators available on fetal medicine, which can help sort of like alter your pretest probability, but I'm just not sure which one is actually better.
Yeah, there's a lot of data on either. I think just in terms of what is available to us at McMaster, we are, I think I see Dr. Serena Gundy's in the grand rounds, the audience, but I know we're working towards perhaps getting PLGF as a marker. I'm more familiar with PLGF because I've used in other institutions in my training as well. But you're right, there are other kind of calculators out there, including the fetal maternal medicine, which takes into account all the biochemical markers, including what we have in this question. Fetal markers and some maternal risk factors as well. So they calculate a score or a potential risk for developing preeclampsia in the context of pregnancy as well. Are there any other?
Yes. Serena wants to comment. I'm sure you want to comment on this.
Oh.
Sorry, go ahead.
I wanted Pete to comment because I just wanted to highlight he's actually been doing a ton of work on this with us in the departments of obstetrics and medicine recently. So he's probably one of the biggest subject matter experts in this, as well as first trimester screening, whether he wanted to be or not. We've sort of we've self-appointed him, and he's certainly risen to the challenge and has a wonderful insight. And I think it goes to show how these patients really are a collaborative effort between medicine, our biochemists, our radiologists, and obviously our obstetricians, because we're not just looking at the short term in terms of pregnancy, but also future. So I'm actually going to let him comment on that because he's done the most research, and I think it's a nice time just to tell the Department of Medicine that there are some things in the works in terms of more sensitive testing that hopefully we can use in pregnancy and beyond. The only other comment I was going to add is actually just a little bit more, and Amanda highlighted it, and obviously, we're thinking about, these patients that we get involved with in the pregnancies, and this is specifically focusing on the hypertension and preeclampsia cases. But really the postpartum, these are your patients, these are our patients 20 or 30 years from now. And, you could do a whole rounds, and I think Arden, and some of the other PGY3s did this a few years ago as well, just on the long-term risks. But so there are going to be new guidelines, because part of the problem is exactly like you answered, like, yes, we know these risks, everybody's in agreement, these risks are there. We can even quote the percentages at this point. The question is what to do about it. So when we say careful screening, what does that mean? Does that mean blood pressure every year, just in pregnancy? So those guidelines are finally coming out this year, hopefully later on in the year, that are going to provide explicit advice around, and actually align with a lot of the other guidelines that are in bits and pieces. Like, these patients should have a blood pressure check once a year. These patients should be screened earlier for dyslipidemia and dysglycemia, and often have concomitant gestational diabetes, which of course, there's already clear guidelines about. But all of that to say, the other thing I wanted to highlight, which is sort of new evidence in the last few years, and more is going to be coming out, explicitly to the patients that you're seeing and you're getting consults on Team E, or you're seeing them in the postpartum period with hypertension. So it isn't just like there's good evidence around treating the blood pressure in pregnancy, and everybody focuses on that. But exactly like you flagged, blood pressure is a dynamic thing in the postpartum period. And there's sort of emerging evidence, particularly in preeclampsia, when we're thinking about that future risk of cardiovascular remodeling, and why it is one of the reasons, aside from the metabolic, complications that walk alongside, put these patients at increased risk, is cardiac remodeling, and also, what's happening with that blood pressure when all of that stuff is happening in the postpartum period. So there's fairly good evidence now to show that tighter treatment, not just in pregnancy, but also postpartum in the first 6 weeks. So patients who have blood pressures, and traditionally we just let them run in the 140s, 150s, even in pregnancy, but after pregnancy, because we said, it's going to come down on its own, or, just take these pills, it'll sort itself out. That tighter control around 120 or 130 over 80 to 90 roughly translates into better blood pressures, like a 5-point systolic difference, which, is getting into the cardiovascular trial, clinical relevant stuff at 6 months and up to now 3 years postpartum, even those who have been off medication. So that initial postpartum period where a lot of the cardiovascular changes are happening and some of the remodeling has happened from preeclampsia may be even more important in terms of something we can do to prevent that future risk, as opposed to just screening and then treating once we find a condition. So there's going to be a lot more, and this is our bread and butter. Like these are internal medicine patients. So it's just important to know that it's not just the pregnancy. It really is for us, the postpartum part. But that was just my add in there. Otherwise, you guys had a monster group of topics, and I thought you did a really nice practical summary of all of them in way less time than I could have managed. Pete, did you want to say anything about the PLGF and SFLET and anything like that?
Yeah, so thanks, Serena, and you're way too kind. Let me just say that it's for Serena, John, others in MF, the maternal fetal medicine program, to let everyone know we're working closely with all the clinicians here, and I really do see the option of PLGF, and we really hope SFLET1 PLGF to be coming to the Hamilton hospitals, and I think it's exciting, and I really commend Serena, John, and others to really kind of be the drivers of this. So more to come, and happy to collaborate.
Thank you, Pete. I want to, take the opportunity that Serena is here still, and Amanda, and all this talk about the impact of hypertension into later in life and what we see in medicine. So, Serena or Amanda, do you want to comment on what we're doing in Hamilton, what you're doing, I should say, in Hamilton, to help with that transition from obstetrics to obstetrical medicine to actually adult medicine or GIM or whoever is interested in carrying on these patients forward, or even with the community physicians in terms of family medicine?
Maybe I'll let Serena comment on this, because she's taken a huge role in leading kind of one of our postpartum vascular clinics at McMaster, who helps. Basically, the goal is to transition these patients from their diagnosis of hypertension in pregnancy kind of to this long-term lifestyle management and support for the family physicians and knowledge translation as well.
I think you summarized it, Amanda, there, but yeah, so we started a clinic, and collectively, Amanda works in it, Connor, Araz, all of us on OB Medicine do this. We've seen, actually, we just hit our 510th patient in the last 3 or 4 years since we started this. And so essentially it's exactly this. It's, because these patients are our future patients, rather than waiting to when they show up 20 or 30 years down the line, trying to identify those that are at a highest level of cardiovascular risk, who are, may go on to develop hypertension, screening for all the other additional risk factors. And then, aside from, and we work very closely with people like Ali and our endocrinology colleagues, because we do also pick up, rare causes of secondary hypertension, preeclampsia, mimickers. But really, the mainstay of this clinic is to try try and, rather than wait till the ship has sailed, really make sure that both the patients and their providers, because there's such a lack of knowledge and knowledge translation in this area, are educated and are aware of a clear screening protocol. And because we know that, with severe preeclampsia, up to 30% of those patients will be hypertensive by the 1-year mark, and a large percentage of it is missed in occult if you're not screening properly. And so it's important to get that out. And also, obviously, this is an area where we need research and we need prospective studies. And so creating these clinics and creating databases and, working together with the other 15 or 16 clinics like this across North America, it allows McMaster to actually contribute to this area. And so there's like 5 or 6 studies running in our clinic right now, looking at various, various interventions, whether they're behavioral, whether they're, therapeutic. And we really, as everybody knows, these patients, although preeclampsia and HDP occurs in probably about 7% of all patients in Ontario. So that's thousands of patients. We're only seeing a small number of them. So we really have to gather who we can so we can contribute to the literature and actually get good research and good studies to say what the heck to do with these patients down the line. So, and Amanda is hopefully going to start another clinic at St. Joe's in the next year or two with this group as well. So more to come, and we're always happy to collaborate with other people because there's a lot of overlap in this area.
Fantastic work. I think Mitch has Dr. Levine has his hand.
So I'm just going to suggest that, if you have an opportunity to do a preeclampsia clinical trial, that you should be comparing beta-1 selective versus unselected beta blockers in the management of preeclampsia. Because if you think about the beta-2 receptor, it is ideally not to be blocked because beta-2 receptors are actually vasodilatory. And by beta-2 blockade, you're going to decrease ureteroplacental blood flow. Just like we do in portal hypertension, we decrease splanchnic blood flow in people with liver disease by giving them a beta-2 blocker. So I really think that this is a question, because I asked earlier if there was any evidence about which one, and I think if there isn't any evidence, somebody needs to do a study comparing beta-1 selective versus unselective, and I think the beta-1 selectives are going to show up as better, less ureteroplacental blood flow decrease.
Yeah, that's a very great point, and duly noted. I think that's a very fair point in terms of the effects on the placental blood flow as well. It's something that is taken into account a lot when we are managing high blood pressure in pregnancy, because even lowering blood pressure too much may have some detrimental effects on the placenta and thus the fetus. And so we are always in conversations with the obstetricians in terms of how strict or how tight to control some of the difficult to control blood pressures in the event that there is evidence of fetal compromise as well. So that's a very, very good point.
Excellent. Great discussion. I don't see any other questions that we're missing. There's one. Excellent review and presentation. Thank you. So I'm just reading the comments. Actually, it reflects what I was going to say. Excellent presentation. Excellent coverage of very important topics. And thank you very much for giving us a lot of time to have a discussion, because the discussion has been very useful as well, and brought in great perspectives. So I've learned a lot today, and I'm sure many of my colleagues did, things that we can bring into practice, and very important things for our patient population. And thank you for focusing on the evidence as you did this. And thank you, Amanda, for supervising and participating in the grounds today. And thank you, everyone, for being here. And I wish you a good rest of your day. Thank you very much.
Thank you so much, everybody.
Thank you. Take care.